Hello everybody, this is Ted Burke and I'd like to welcome you to our third of our winter webinar series webinars. This webinar this afternoon is on Down syndrome, an updated look. We're very excited today to have two presenters, Dr. Karen Landmeyer from the University of Chicago and Pat Singler from Easter Seals of Metropolitan Chicago, which I spelled wrong. Sorry about that, Pat. We also have two moderators today, myself, Ted Burke. I'm the director of the Early Intervention Training Program, and we also have Maria Maddox with us, who will be our moderator not just for this, but for all of our 17 webinars. So you'll get to know Maria very well if you participate.
All right. So we have another poll that we're going to just kind of jump right into, that our presenters are kind of curious to know if you have an idea if the statement is true. So in approximately 95% of children with Down syndrome, this condition is not inherited. Is this a true statement? Yes or no? And we'll give you a chance to answer that question.
Sorry, Maria, I jumped the gun and I published the results too soon.
See that. Well, it appeared that pretty much overwhelmingly most folks were saying that that this is a true statement. So, Karen, I'm going to turn it over to you, and I'm going to let you take over.
And just to further introduce myself, I am Karen Landmeyer. I'm a fellow in Developmental and Behavioral Pediatrics at the University of Chicago. And I'm joined today by Pat, who is a mother. So we're both going to be giving you our thoughts. And first, I just wanted to say that I am from Colorado, so it's very exciting to see people from all over Illinois. I'm still learning the suburbs of Chicago, let alone the outlying regions. So I'm happy that so many are here today. To answer this first question, as the majority indicated, this statement is true. Only 3 to 5% of cases are inherited, and the rest arise as an accident of chromosome arrangement during meiosis, which I'll briefly describe in a minute. So just to bring everyone to the same page, Down syndrome is a genetic difference that occurs at conception, and therefore nothing in pregnancy can cause Down syndrome to occur. So 95% of cases are caused by non-disjunction, which I will describe in the next slide. 3 to 4% of cases are caused by something known as a Robertsonian translocation, and that is what would be an inheritable cause for Down syndrome. So less than 5% can actually be inherited, and then the remaining 1% is caused by mosaicism, and that means that part of the cells have a normal number of chromosomes, and part of the cells in the body have an abnormal number of chromosomes. And I won't get into that too much. It's a little bit outside the scope of this presentation today. But just to explain the most common cause of Down syndrome, I want to bring you all back to the chromosomal arrangement. So the pairs of chromosomes are supposed to split up and go to different spots in the dividing cell, and that is known as disjunction. However, occasionally one pair doesn't divide and the whole pair goes to one spot. So that's indicated by the red arrow on this slide. This means that in the resulting cells, one will have 24 chromosomes and the other will have 22 chromosomes. When that happens, it's referred to as non-disjunction. So if a sperm or egg with an abnormal number of chromosomes merges with a normal mate, the resulting fertilized egg will have an abnormal number of chromosomes. In Down syndrome, the difference is caused by an abnormality in the 21st chromosome, and that's why it's also known as trisomy 21. recent research has shown that in these cases, approximately 90% of the abnormal cells are the eggs. The cause of the non-disjunction error is not known, but there's definitely a connection with maternal age. And that brings us to our next audience response question. So more than half of all babies with Down syndrome are born to women under 35 years old. Is this a true statement?
We'll give folks a few seconds to respond. Make sure you're using your poll function, that fourth icon directly under your name, to respond to the poll. Let's see what results pouring in. A few more seconds we'll give it. And all righty, we'll go ahead and close this one out and post results. So, what were your answers? 61% of you felt that this was a true statement, that more than half the babies with Down syndrome are born to women under 35 years old, and 25% of you...
No, actually, no, Maria, that's the other way.
Okay, thank you.
61% said no.
Thank you.
Sorry.
Thank you. Yeah, I'm getting my reds and blues correct. So 61% of you said no, this was not a true statement. Thank you, Ted. And 25% of you said yes. So, Karen?
And that is what most people think, which is why I asked this question. But this is actually a true question. About 80% of children with Down syndrome are born to mothers less than 35, and that's because women under 35 have more babies than women over 35. Sometimes this is confusing because of the maternal risk over 35, but overall more people have babies under 35. So just for the interventionist, when you know that you're going to meet a family with Down syndrome, I think some of us automatically think, oh, it's probably an older mom, but there's actually a higher likelihood that it will be a young mom. And this is the last audience response question. So what is the best predictor of life expectancy? Communication ability, socioeconomic status, medical problems, self-help skills, or education?
All right, folks, use your poll button to respond to this poll. It is the fourth icon directly under your name with either a letter or a checkbox in it. We've got responses coming in. We'll give folks a few seconds to respond here. A few more seconds. Okay, let's see what we came up with. So it appears that 57% of you felt that the best predictor of life expectancy is related to an individual's medical problems, with some of the similar thoughts, about 9, 10, 13% felt socioeconomic status, and self-help skills were also indicators. So, Karen, what's your thoughts on this?
The answer to this question is self-help skills, which is probably surprising to a lot of people. But there was a study done in California in 1991 that looked at over 12,000 people with Down syndrome and found that major medical problems were not a consistent predictor of mortality, which was a common belief. Instead, self-help skills were the best predictor of life expectancy. Adults with Down syndrome and good self-help skills, such as mobility and self-feeding, could be expected to live into their 50s. And keep in mind, this was in 1991 before there were very good medical advances in some of the areas like the cardiac defects. while those with poor self-help skills were expected to live into their 40s. So with so many things changing medically and socially in the next decades after this study, it's not good to extrapolate from there how long we would expect a child with Down syndrome to live now, but it's just an indicator that the developmental therapists, the occupational therapists certainly have a really significant role in the care of these children because we know that self-help skills are so important to them. So now Pat's going to speak a little bit about her personal experiences with Down syndrome.
Okay, hello everybody. My name is Pat Singler, and I am the parent of 3 children, 2 of whom have Down syndrome, and that is their picture that's up with the slides right now. My daughter Gretchen on the right is 25 years old, and my younger daughter Beatrix, who has changed her name to the letter B now, is 17. So I definitely have a vast amount of experience with Down syndrome and all the medical issues involved with it. My oldest daughter when she was born, the physician knew right away by her appearance that she most likely did have Down syndrome. But with so many of the individuals with Down syndrome, when they are born, sometimes there are medical complications. And my daughter Gretchen had a duodenal blockage that needed to be repaired immediately, so the focus was more on her medical condition, and along with that, so many of the individuals, and Karen will speak to this, have a cardiac defect, and she had that as well. So that was quite a bit thrown at us at that time, but then we also were aware of supports that might be available out in the community, and the main reason why was because we were involved with an organization that serves primarily the Chicago area called the National Association for Down Syndrome. And so we had a support mom come out and speak to us about early intervention and speak to us about her experience as a mom. And I will probably thread that throughout the webinar, that was so incredibly key to my family, and I think it's so important for families to have the connections. So we were not able to enter. Now, mind you, this was 25 years ago. We were not able to receive any early intervention services for 9 months because there was a waiting list to receive services. So in the meantime, we as a family were more focused on her medical needs and kind of kept her isolated so that she would be able to gain weight and have her cardiac surgery, which she successfully did. And on we went. My younger daughter, because I was statistically of the higher maternal age, I reluctantly agreed to have some prenatal testing. So I did know before she was born that she did have Down syndrome. I do have to admit that I focused on, due to that testing, that was indicated that she might be higher functioning. And so I was pleased to hear that and hope that, again, she would have a very good outcome, which she did. She also had cardiac issues, the typical cardiac defect, which is called an AV canal, which, again, Karen will speak to, and that was successfully repaired as well. And because the early intervention system actually changed over that year that she was born, we were able to receive services right off the bat. And so later I'll talk about early intervention and its effect in our family. Definitely took the ball and ran when my second daughter was born, simply because we had the background with my oldest daughter in connecting with other folks. And again, that was the most key piece, was connecting with other folks. So it's been interesting, and they can be challenging, and they have some interesting behavior sometimes. And I will speak later to what life is like with an individual with Down syndrome, and especially 2 of them. But I thank you for the opportunity to speak to that component of our lives. You kind of forget about all those diagnoses and way back when, so it's kind of interesting to revisit that. So I'll turn it back over to Karen.
All right, thank you so much, Pat. And if anyone has specific questions at any point for Pat or I, feel free to type them in the chat box and we'll try and answer them. We're going to switch over now to the medical aspects of Down syndrome. Children with Down syndrome are in need of the same kind of medical care as other children. The pediatrician or family physician should provide general health maintenance, immunizations, attend to medical emergencies, and offer support and counseling to the family. There are, however, situations when children with Down syndrome need special attention. So in these next slides, I'll be speaking specifically about those areas. 60 to 80% of children with Down syndrome have hearing deficits. Therefore, audiologic assessments at an early age and follow-up hearing tests are indicated. If there's a significant hearing loss, the child should be seen by an ear, nose, and throat specialist. And just a word to the interventionist, if you notice changes even from 1 month to the next month that makes you concerned about a hearing change or difference with the child, it is important to bring that up with the parents because these children can have frequent ear infections and that fluid in their ears can really change the way that they are able to hear and therefore the way that they are able to learn. There's a very high incidence of obstructive sleep apnea in these children, and parents often underreport their symptoms. Some characteristics that are concerning for sleep apnea are considered quote-unquote normal for Down syndrome by the parents, but some warning signs are sleeping with the head hyperextended, such as the boy in this picture, sleeping in the sitting position or bent forward at the waist, and awakening several times during the night. So sleep apnea can really cause significant problems, and it can impact both behaviors and the ability for the child to learn. As Pat mentioned, cardiology is also a significant component for some children. 40 to 45% of children have congenital heart disease, and many of those will have to undergo cardiac surgery and will often need long-term care by a pediatric cardiologist. There have been studies specifically looking at the language development in children who have required cardiac surgery, and it shows that they do have a longer period until they are gaining the same skills as their other peers with Down syndrome who have not had cardiac defects. So it's important for the speech and language therapists to keep in mind. Intestinal problems also occur at a higher frequency. For example, a blockage of the esophagus, the small bowel, or the anus are not uncommon in infants with Down syndrome, and those need to be surgically corrected at once in order to have a normally functioning intestinal tract. Other concerns relate to the nutritional aspects. Some children, in particular those with severe heart disease, often fail to thrive in infancy. So weight gain is a very big concern for them. On the other hand, obesity is often noted during adolescence and early childhood. So both ends of that feeding and weight gain perspective can be prevented by providing appropriate nutritional counseling and anticipatory dietary guidance, and also just guidance with the families to work with their pediatrician to really monitor the growth when the child is young. These children often have more eye problems than other children. For example, 3% of infants have cataracts, which need to be removed surgically. Other eye problems such as strabismus, which is cross-eyed, nearsightedness, farsightedness, and wandering eyes, esotropia or exotropia, are frequently observed. Some children with Down syndrome can also have nystagmus, which is a jerking movement of the eye, and this can be normal in some children, but it should be evaluated by an ophthalmologist. So if you're seeing that as an interventionist, it's good to raise that concern with the family just so that somebody is monitoring it. I think sometimes these families have so much going on, and if, for example, their child has had a surgery early in life, then little things such as hearing or their eye movements might not be a focus to the family. So you who are working with the children can help them with those other aspects. I couldn't find a cute picture of a thyroid. So between 15 to 20% of children have hypothyroidism, and it's important to identify those individuals because hypothyroidism may compromise normal central nervous system functioning, and again, that can impact the child's growth and the child's learning and development. Skeletal problems have also been noted at a higher frequency, including kneecap subluxation, which means incomplete or partial dislocation, hip dislocation, and atlantoaxial instability. So this picture is a cartoon to demonstrate the atlantoaxial instability, and that occurs when the first two neck bones are not well aligned because of the presence of loose ligaments. And so the concern here is that that top neck bone will move over the second neck bone and could compress the spinal cord. Approximately 15% of people with Down syndrome have this atlantoaxial instability, but most of those individuals do not have symptoms, and only 1 to 2% of those individuals with a serious neck problem actually require cervical intervention. So it's something that just needs to be monitored. We guide the parents if the child is starting to have incontinence after they've been toilet trained, if they're starting to have weakness or a change in their gait. Those would be concerning signs for spinal cord compression. And other medical aspects in Down syndrome include immunologic concerns, leukemia, Alzheimer's disease, seizure disorders, and skin disorders. These conditions may require the attention of specialists in their respective fields, but I want to bring your attention that just because these conditions occur more frequently in Down syndrome than in the general population, it doesn't mean that all or even a majority of people with Down syndrome will develop these problems. Take, for example, leukemia, which in this slide you can see occurs in 1% of children with Down syndrome. That's still a very small number. It's only notable because it's more frequent than leukemia otherwise occurs. So sometimes there's a lot of talk about all people with Down syndrome will develop Alzheimer's disease, and that's not true. It's just that we know sometimes that their brains will develop the plaques that are also seen in Alzheimer's disease. I just want to address Kay's question that says, due to these neck concerns, are there any impact on therapy? There should not be any impact on therapy as long as the child is not exhibiting those warning signs that I talked about. And the latest guidelines have actually taken out a precautionary neck x-ray because they found that these children do so well and so few of them have a problem that we don't need to be screening all of them by x-ray. A lot of times if they do participate in Special Olympics will require that, but as a young child there should not be any restrictions unless there has been a noted skeletal abnormality or, again, those red flags. So cognitive impairment is also common and usually ranges from mild to moderate. Only rarely is Down syndrome associated with severe cognitive impairment. Some other common cognitive and behavioral problems might include a short attention span, poor judgment, impulsive behavior, slow learning, and delayed language and speech development. Most children do develop the communication skills they need, although it might take longer for them to do so compared with their typically developing peers. And early ongoing speech and language interventions to encourage expressive language and improve speech clarity are particularly helpful. So the goal is for the child to be able to communicate not just with their family, but to be able to communicate in the community. So the clarity of their articulation is very important, and even the ability to communicate such as using signs is really helpful for these children to decrease their frustration. So again, we're going to have Pat tell you a little bit more about her experience.
Okay, thank you, Karen. Yeah, so my oldest daughter, Gretchen, I could check many of those medical boxes for her. She has had, she has a moderate hearing impairment, she has nystagmus, she's had 3 cardiac repairs and has a mechanical valve and is permanently on a blood thinner. For that, has some ambulation issues, so she really has some medical concerns, and yet she is a thriving individual who is in a day training program and goes to her job every day and communicates with somewhat unintelligible speech, but also uses sign language as her primary mode of communication and can certainly let us know her needs. My youngest daughter has a lot of language and is a little bit higher functioning, and she is in a Chicago public high school and is doing very well with pre-vocational programs, and medically, other than the 1 cardiac repair, she is doing well. So in that sense, the medical component maybe, as Karen alluded to, maybe had some impact on Gretchen's overall development, but yet she is a happy individual, and as parents, that's what we want. We want to be able to give our children the most opportunities that we can, and what we want is for them to be happy. I do know, anecdotally, other individuals who have had a huge range of issues. There are individuals who are young adults who have very little language, but yet are able to communicate reasonably with what they need to their families and in their community. Our girls are out in the community a lot because we are very involved with Special Olympics, which does require the neck x-ray to participate. And again, that has been a lifesaver for us, and it's just been wonderful for them. So we definitely have taken some of the medical challenges and worked through them with our girls, and they can absolutely become completely involved in our communities as young people and adults. I'm trying to think what else I could tell you. One thing I did want to say, though, too, about when I was pregnant with my oldest daughter, and I want as EI interventionist for you to be aware of that, is the maternal gut feeling. I somehow knew intuitively that she would have Down syndrome before she was born. And when I was involved with my support group later on, there were 2 other moms who had that strong sense as well. And that strong maternal sense has definitely carried through our entire lives together. So that what is difficult with our individuals is sometimes puzzling out when they're not feeling well and what are some of the medical issues. So we do tend to run to doctors a little bit more because we're always second guessing ourselves. But I really want to speak to that strong maternal instinct with our children, and just sometimes as therapists, I know working with families, you're thinking, well, we should be doing it this way, and a mom might be giving you a little pushback or wants to step back a little bit, or they want a little more, and you know, there's an instinctual feeling that we carry with our children. So I just want I just want to acknowledge that, because I forget about that I felt that way, but there are other families that feel that way as well. And anyway, I'll speak later about support groups and that sort of thing. So Karen, I'll go back to you now.
Before we switch over to Karen, Pat, there was a question that Pamela asked, and she was wondering if there was anything that you physically or mentally did to prepare you for your second daughter's arrival.
No, not really. Having the experience of my older daughter, I knew what to expect, I guess. When families have their babies with Down syndrome, what we are always looking for are the markers. When are they going to sit up? When are they going to roll over? when is speech going to come in? And so I suppose I was paying a little bit of attention to that, but I wasn't as hypervigilant about it because I knew it would come. And very often that's what support groups will say to families. That's their concern is, okay, so when are we going to do all these things? Hurry, hurry, hurry. Let's hit these milestones. And yet our children do them. It takes longer to get there. So it was easier because I didn't have any pressure of anticipating when it was going to happen. I knew it was going to happen, and it was going to be her time frame. It wasn't going to be my time frame.
Thank you. Pat, there's also another question for you from Rebecca, and she wants to know if your third child had any difficulty with having siblings with Down syndrome.
Oh, that is a great question, and I'm glad somebody thought of that because I forget about that sibling aspect. And we all do because we are so focused on our child with special needs that we forget about the typically developing sibs that are around. And I will say this, and I do remember doing this when I was taking my daughter to her early childhood program at a Chicago public school. I would carry her and make her brother, who was 18 months younger, walk. But I would carry Gretchen, even though she could walk, not well, but she could walk. And I feel as if I probably was ready for him to hit his milestones at a faster pace just because it was almost like having twins. And so I don't know if he ever felt that way. I think sibs feel strongly that they are required to pitch in and help, but also everybody in the family, I mean, I'm thinking of all the families that I know, tend to support the family dynamic of we have this individual and I'm going to support my parents. And do I feel left out sometimes? Yes, but we made sure we went to all the sports events of my son and all that sort of thing. So it is a difficult mix. There are entities that have sibling support workshops. In the Chicago area, there are a couple of hospitals that do, and I'm sure that there are downstate so that they can address the sibling issue. But thank you, great point.
Thanks, Pat. I don't see any other questions at this time specifically to you. So if you're ready to turn it over to Karen. Karen, there are a few questions that have come up for you. And one of them had to do with, again, the neck instability. And there was a question about, is there any impact on early intervention or therapy related to the neck concerns? All right, Karen? We may have lost a little bit of audio for Karen.
Are you able to hear me?
There they are. Yes, thank you.
Are you able to hear me? Okay, so early on I would just emphasize the importance of working with a family to know if their pediatrician or any of their physicians have indicated a problem with the neck, and if not, there should not be any restrictions unless those warning signs are present.
Okay. Dawn has a question. As an SLP who specializes in feeding therapy, she's noticed that the children with Down syndrome that she served who've received early focus on feeding and oral motor skills as infants have presented with higher speech articulation skills as they've become older. Does anyone else notice this with the children they're seeing as well? Karen, any comments on that?
I think it's a very interesting observation, and it might emphasize the challenges with their oral motor tone. I haven't read or known about the outcomes based on early work with oral motor function, but I think that it probably is an excellent idea for all of these kiddos. And if anyone wants to type in the chat box if they've had experience with that as well, I think it's a nice anecdotal piece of information to keep in mind.
Right.
Okay. So
as most of you can tell, Karen has been responding to a lot of your questions in the chat box. So if there are any, please continue to ask your questions, and we'll give you another opportunity for our presenters to respond in a little while. Thank you.
Okay. Thank you for those questions. We're going to move our focus into early intervention and education now. So today, early intervention programs, preschool programs, and integrated special education strategies have demonstrated that youngsters with Down syndrome can participate in many learning experiences which can positively influence their overall functioning. Research has shown that early intervention, environmental enrichment, and assistance to the families will result in progress that is usually not achieved by those infants who have not had such educational and stimulating experiences. So the work that you are all doing is very critical to these patients and their families even. Also, early intervention may improve the social quotient for these individuals, although the level of functioning is extremely variable. These children often function more effectively in social situations than would be predicted by their cognitive development. Later, the school can give the child a foundation for life through the development of academic skills and physical as well as social abilities. Experiences provided in school assist the child in obtaining a feeling of self-respect and enjoyment. School should provide an opportunity for the child to engage in sharing relationships with others and help prepare the child to become a productive citizen. Contrary to some views, all children can learn, and they will benefit from placement in a normalized setting with support as needed. A couple support services that Pat and I wanted to make sure that you're aware of. The Family Matters Parent Training and Information Center serves 94 Illinois counties, those outside of the Chicago area, and 95% of these programs are funded by the U.S. Department of Education with some additional support from the ARC community support systems. For those of you who are in metropolitan Chicago area, the Family Resource Center on Disabilities is a nice resource to help families connect with early intervention and as they move into the educational realm. Dual diagnosis is a term applied to the coexistence of the symptoms of both intellectual or developmental disabilities and mental health problems. One study reported that 18% of children with Down syndrome younger than 20 years old had a psychiatric disorder. Most frequently, that was a disruptive behavior disorder, such as aggressive behavior in 7%, ADHD in 6%, or conduct and oppositional disorder in 5%. However, compared to other groups of children with cognitive impairment, those with Down syndrome as a group are less likely to have behavioral or psychiatric disorders. Approximately 7% of Down syndrome children will also have autism spectrum disorder. It is critical for this group of children to be identified as early as possible, just as is the case for children with autism alone, because of the impact on educational and therapeutic interventions, and in some cases the need for further medical assessments and treatments. Many individuals with a dual diagnosis of autism and Down syndrome have a history of developmental regression, approximately 25%, and that number is the same in children with just autism. It's about 25% who will have regression. However, unlike autistic regression in children without Down syndrome, the time period for this regression may be later. So typically a regression in a child who just has autism is between 18 and 21 months of age, but for children who also have Down syndrome, that regression can occur even between 3 and 5 years old. So the pattern of regression for both groups is similar. It can be a language loss, a skill loss, or a combination of those two. Sometimes when children with Down syndrome have undiagnosed medical problems, such as earaches, toothaches, headaches, any type of undiagnosed problem that can be causing them pain or discomfort, they may display autistic-like behaviors, such as self-injury, irritability, or aggression. And likewise, some autistic-like behaviors can result from a stereotypy movement disorder, depression, obsessive-compulsive disorder, anxiety disorder, or exposure to extreme stress. So a comprehensive medical exam is necessary to rule out the other reasons for autistic-like behaviors. Just a final message about this for the providers. Children with Down syndrome and autism spectrum disorder are clearly distinguishable from children with Down syndrome alone, or those who have Down syndrome and severe cognitive impairments. So an 18 to 24-month-old with Down syndrome who is not showing, imitating, or making attempts to elicit attention needs to be monitored more closely. And again, in my experience with seeing some patients, I think that families who have children with Down syndrome do not even know that their child could also have autism, so they might not be looking at those symptoms as another child would, or another parent would be looking as a possibility of autism. So it's really important for you as providers, if you're seeing those symptoms that indicate a difference in their social responsiveness, to bring that up with the families and encourage them to seek more consultation about that. So in the remaining few slides, I just wanted to give some resources for the different disciplines for the interventionist here. And I'm going to start with some behavioral and developmental resources. One thing that is interesting about working with children with Down syndrome is that their relative strengths are visual spatial processing, receptive language, and social relatedness. So the first two of those, the visual spatial processing and receptive language, are very similar to kids with autism spectrum disorder. So if you are working with a lot of kids with autism and you have nice strategies to help them, a lot of those strategies can be carried over to working with children with Down syndrome. And the nice thing is their social relatedness even makes them a little bit more responsive to these strategies, because they do have an interest in their relationship with the provider. So some of these resources can work for both populations. This is a resource for language interventionists. It's based on the Hannon series, and it's nice to help the parents have some ideas of how to work with their children. This next resource is similar. This is also a language resource, and you'll see it is specifically for children with autism spectrum disorder, but these tools work just as well for children with Down syndrome. They have a really nice response to these. This is a nice resource for the gross motor skills. As Pat mentioned, some of that anxiety that parents might have of when should they expect their child to sit, when should they expect their child to crawl or walk, is outlined really nicely in this book. So for the interventionist, that might be a nice tool to help families at those times. I didn't have a nice resource for the occupational therapist, but conveniently, Katie Frank, who is an occupational therapist at the University of Illinois at Chicago, recently published this article that talks about the fine motor and self-care milestones. So if anyone would like a copy of this, I believe that you could email Susan and she could let me know, and I should be able to share that with you. And finally, there's been a big push recently to help families become advocates for their child's medical care. So this top form is a clinical guideline summary for physicians who care for children with Down syndrome, and they have made that into a little bit more digestible report for the families, which is the one shown below. If you Google and look for that, that's a resource that's really nice for the families to know what should be monitored at what age of life. And it's just really important for these families to feel empowered and taking responsibility with their child's care, because they're the one that really knows the child the most. And then this is the final slide. I just wanted to end with what Pat had been speaking to earlier. The importance of support groups for these families, it cannot be emphasized enough. So there are support groups all around the state. As she said, NADS is kind of a resource that can link families up with support groups in their areas. Gigi's Playhouse is located in several parts of the suburbs of Chicago, and then down in the Southland and Down Syndrome Support Group are both located in the south suburbs. Ups for Downs is located more in the north suburbs. DADS is a really nice support group because a lot of fathers will comment that they feel that they're kind of navigating this new territory by themselves. And then again, National Down Syndrome Society is a nice collaborative group in the entire country. So I'm going to finish with that, and I'm going to let Pat wrap up with her piece.
Okay, thank you, Karen. Yes, those support groups are key. With natural environment being the most important aspect of early intervention, a key piece is missing from families' early intervention experience, and that is support with other families. I will have to say, many years ago when I was in early intervention, those folks that I met through my early intervention program, who I still know some of those individuals today, were so important to my life at that time. And I could tell you every one of their names. And so as early interventionists, what I am saying is your families will remember you. They will remember their experience with you because it is such a critical time for them. Families are getting used to their new life. They're getting used to what it is like to have a life with an individual with a special need, and what they receive from the early interventionist is acknowledgement that your child is important, your child has great potential, and we are going to work on this and support you with this. So that's a really, really key time for families. So I just really want to speak to that. I know many families are so sad when early intervention is done. And with my oldest daughter, if you can believe this, she was actually allowed to stay in early intervention until she was about 2 years, 7 months. I'm sorry, 3 years, 7 months, because the system was so different back then. And I was so afraid to go to the school system. And so you all are so very important to the families, and so you're important in that you are the people that are going to guide families and create some support for families, because the groups, they're just not out there as they were 25 years ago. They just don't exist because everybody is keyed into the internet. So families, what they're doing is they're blogging and they're connecting through groups such as that, but there is nothing like the face-to-face. I have always said the most important time at a meeting is when everybody walks out the door and they're standing on the sidewalk and they're talking to the other moms. And that's when they're sharing doctors and support groups and therapists and just kind of talking about what it's like. And so I encourage you to encourage your families to key into any supports that they can find that are out there. I am very involved with Special Olympics. They do have Special Olympics for little guys, so that's something else that families can start to get their child involved with as well. My daughters swim, they do gymnastics, they are on bars, they're tumbling, they're playing basketball, they're going bowling. It's a lot of work. I'm not going to say it's not a lot of work, because what our children have is they have supports, and families are great, and families are supportive, but as our children get older, we find supports start to fall apart, those really close supports, and we start looking at other families and other entities to help support our lives as parents and as family units with an individual with special needs. And so I cannot tell you the support. I have very close friends that I've had for 25 years, and these are the friends, yes, it's called black humor, where we laugh about some of the quirks that our children, our young adults exhibit, and just share stories. And again, that I just cannot speak strongly enough about how important that is to try and seek that out and how to foster that for families as well. When families are in early intervention, I did see a comment about how many sessions should families have per week, and I know that there are some families that really, really want a lot because they think more is better. I was a family that I started to pull away from services as my daughter got a little bit older, say the age of 2 and 2.5, because it just became so overwhelming for me. Not everybody is at that place, and it's just being patient with where families are at and their perspective. What I didn't say is that I work at a CFC and I'm an LIC coordinator, and I work with a lot of service coordinators, and I feel that sometimes people have difficulty understanding where families, what their perspective is as parents at that place and at that time. So again, as therapists, you're so supportive as far as for families receiving in general information about their child, but also from an educational point of view too, because all of these little guys are going to go into a school system, and nobody holds hands better than early intervention, and nobody lets go of the hand better than a public school system. And so that's when therapists really, really are so helpful for families when children enter the public school system. And there are a lot of support groups out there. I know there's Family Resource Center and Family Matters. Some of those books that are on the screen now, when my daughter was younger, 1, 2, 3 Magic was the big one. That's the one we all used. Speaking, again, anecdotally, our children can be sometimes challenging. They have some very strong-willed behaviors. They can do a little running where you're chasing them down the block, and can be quite impulsive. My youngest daughter is very in tune with technology and has disabled my iPhone about 2 times because she is able to answer. She answers emails and she answers phone messages, and I have a really hard time keeping ahead of her. So I've got kind of the broad spectrum of where people are at with Down syndrome in my family. But on the other hand, for every challenging behavior, there is not a group that will unconditionally give a family so much back, so much love, so much that you can yell at, you're yelling and you're wagging your finger and they will smile. Try and turn it around. They can be, my children can be a little bit manipulative, and they're like any other child, and that's how they are. Our individuals with Down syndrome are as babies and as young adults. So I have this broad perspective. I appreciate the opportunity to speak to how important early interventionists are for families in the birth to 3 time frame. And I noticed a question about funding and resources, adult resources, and there's a lot out there for that. I could actually email people some of those resources, but there are groups that provide all of that sort of information. I know the ARC is pretty good on having workshops for that specific type of adult information. So that is a resource that's out there as well. So I thank you for the opportunity and to speak about my daughters and about individuals with Down syndrome. I know many of them, and I know them from A to Z. They have a broad range of capabilities and abilities, but there's always a smile and there's always a hug, and they're a joy to be around. So thank you for the opportunity.
Thank you so much, Pat. There was another question about the resources, and it came in from Kay, wondering if any of these resources offered respite services for families.
Respite is really difficult. Our Family Resource Center for Disabilities used to have a published list, and they no longer publish a list because funding is very limited. A lot of times that's a grant-funded program, and I know it's depending on the state of the state as to whether it is continued to be funded. There are long-term resource groups, but there is no list that I know of out there other than some individual agencies, and I'd have to look for that and see what I can come up with for that. That's difficult. It's very difficult.
Yes. It looks like you addressed a lot of the questions that were coming in through the chat. So, are there other questions for Karen? I was looking through here, and the question about services, Pat kind of addressed. Did you want to say anything about services, early intervention services for children, Karen? And
I just
Karen is on.
Will echo what Pat said. That are you able to hear me now?
Yes.
Okay. I just will echo what Pat said, that some families do have a sense that more is better, but I think that all of it should be framed around that individual child. So there's no particular formula or recipe for the number of times a week, the specific therapies, when they're started or how they're started. I think it needs to be tailored to what the family situation is, meaning if the child has just undergone surgery, if they need to focus on different areas, or if the child is having challenging behaviors that are precluding them from having good therapies. It really should be tailored to that particular child. But as I said, just to reemphasize, self-help skills are really important. As Pat said, mobility will come. It will be delayed, but it will come. And speech and language, we cannot underscore the importance of that just for their long-term ability to function in the community, to relate with their families, their peers, and their friends.
All right, thank you for that. And I was looking through the chat log here, and other than some confirmations and verification that they just love this webinar, I'm not seeing any other questions other than Karen does have a question about if Clearbrook still has the Take a Break program. But Karen, is there anything else you'd like to say in wrapping up?
No, thank you all for participating today, and I just will encourage, if you haven't watched the video that Susan sent out, I would encourage you to do so. It's a very nice video.